and to assess other organ involvement with the complications and to identify the largest and safest node for the biopsy. There were multiple enlarged lymph nodes in the bilateral supraclavicular region, axilla, mediastinal, and hilar regions, with one of the largest lymph node in the right axillary region, which was measuring 2.4 by 1.7 centimeter. Multiple enlarged lymph nodes were also there in the gastrohepatic, portocaval, periportal, and outercaval nodes, with the possibilities of chronic granulomatous conditions like sarcoidosis, tubercular lymphoma, and multicentric Castleman disease.
How common is your last diagnosis?
So that would be discussed in the further slide.
My question again comes is chronic sarcoidosis, tuberculosis, lymphoma. I agree they are common things, but when I look at multicentric Castleman disease, it's a very rare entity.
Yes, sir.
Putting it as a diagnosis over here, possible diagnosis, I don't think it would have struck the mind at this point of time.
Sir, actually, in the
maybe that's a diagnosis. I don't know what we're looking at, but then we get biased. What we're presenting is a biased diagnosis over here. Would you really think of a multicentric Castleman's disease with these findings at this point of time?
No, sir. It will not be with the relative investigations. Now, I would like to invite Dr. Kaushiki Shukla from the Department of Nuclear Medicine to discuss the PET-CT aspect.
I think you go for a lymph node biopsy, excellent biopsy. That's the most important investigation.
Sir, actually, just to see the metabolic activity of the lymph nodes, after the PET, we have advised for the external biopsy. All the things are going simultaneously. With the CCT, we advise the external biopsy and PET-CT both.
It's a very simple thing.
Sir, external biopsy was advised just immediately after the CCT.
Should have been done. Not advised.
Actually, patients had multiple biopsy failures in the past, like short in local hospitals.
That was FNC.
So, FNC also. And
Biopsy was also.
yes, and one excision biopsy was also attempted, which did not really happen. So this time.
Yes, sir. Sir, biopsy was done earlier, before to that, and there was no relevant
Mentioned not in the hospital. Have you mentioned it? They mentioned, but it was done outside.
Yes, sir. They were done outside, and no significant diagnosis was done before to that.
Outside in the
Yes, sir. There was some difference.
it is different thing altogether. You can come to some conclusion. But the slides can be reviewed. Yes,
But we don't have slide the outside slide.
outside we can get that. Always there is the procedure to get the histopathology review. बहुत बड़ी चीज है हम ये स्लाइड तब दोबारा ले लो
Yes, sir. We had done, sir. We had done.
External biopsy was.
We had done simultaneously with the CT PET and according.
What I'm saying, you are teaching your guys. Before advising them for PET-CT, you should go for biopsy.
See, biopsy would have changed the plan of investigations also. Suppose you get confirmation that this is tuberculosis, you will not do PET.
Yes.
You will put the patient on ATT. You may not have FNAC and biopsy.
Sir, I want to add one point. In PET-CT, I read the target sites. Here we can produce the most producible biopsy results. Most of time there are generalized lymphadenopathies existing in the most of the patients and most of the general people also. So we have to select the which node and which site is most reproducible for the results. Is also
Here there are obvious large nodes in the neck, 2 centimeter. If you take out that whole node, that will give you the diagnosis. There is no need to go into the mediastinum or a common or a difficult to access area.
But sir, in the
She's 70-year-old female coming with multiple lymph nodes. Think of malignancy somewhere.
Sir, in the malignancy patient,
There is no question on PET-CT. Thinking that what should be done first.
Yes, sir. Biopsy is the first investigation has to be done. And because we are thinking कि पहले भी हो चुकी है और हमने साथ में
slide is possible. You have to repeat it.
If we take it in general, at present, if I take a biopsy, my first diagnosis could have been a lymphoma.
Yes.
Yes, sir.
I mean, that could have been clarified easily in the lymph node biopsy.
Good morning, everyone. I'll be discussing the PET-CT findings of this patient. This was the maximum intensity projection image of the patient, and this is the injection site. according to this image, we saw multiple foci of increased FTG uptake in the cervical, mediastinal, axillary, abdominal, pelvic, inguinal, and femoral regions, with an isolated appearance of increased FTG uptake in the cuboidal region on the right side. Since the patient presented with cutaneous symptoms, we darkened this MIP image to look for metabolically active cutaneous lesions. This is the darkened image, and there was no other uptake on the cutaneous lesions. These are the representative coronal and axial images of the patient that show generalized lymphadenopathy in the cervical, mediastinal, axillary regions. And this axial region shows generalized lymphadenopathy, and the maximum SUV max was noted at the left cervical lymph node, which was 7.98. And this is the supraclavicular lymph node on the right side, showed the maximum uptake of 6.97. These representative images show axillary and mediastinal lymph nodes, where the left axillary lymph nodes showed an uptake of 8.33, and this is the abdominal lymph nodes. The left para-aortic lymph node showed an uptake of 4.67. These are the representative images of the pelvic, inguinal, and femoral lymph nodes, and these are the representative lymph nodes. In this particular image, we can see that there is increased uptake in the spleen, which indicates the splenic involvement. And in this image, you can also see that there is hepatosplenomegaly, and you can also see this is the isolated right-sided cuboidal lymph node. So, how do we differentiate it from the other pathologies like TB? We look at the nature of the lymph node. This is our representative lymph node, and you can see that the concavity and the convexity of the lymph node is maintained. There is no necrosis noted. You can see this dipping here, which indicates a preserved fatty hilum. Our final diagnosis was there were multiple lymph nodes on both sides of diaphragm. They were non-matted, non-conglomerated, and were discrete in nature. There was no necrosis. They were enlarged in size but with preserved fatty hilum and showed moderate FTG avidity.
These are findings, it's not the final diagnosis.
Sorry, sir. These were the findings. There was organomegaly with increased uptake in the spleen, which was 7.3. There was diffuse increased FTG uptake in the bone marrow as well. So, since there was no necrosis, tuberculosis, sarcoidosis, and other granulomatous conditions were ruled out. Preserved fatty hilums of the lymph node. So, malignancy was less likely, like other metastatic and hematological malignancies were less likely. Here were our differentials, which was Castleman's disease, Kikuchi disease, autoimmune diseases, and viral diseases. Since viral diseases and autoimmune panels were already done and ruled out, our two differentials were Kikuchi disease and Castleman's disease, with malignancy being less likely. Now,
ruled out lymphoma?
No, sir, it is less likely. Because most of the
large, fleshy, uniformly enhancing nodes with no necrosis.
But sir, there was also, most of the lymph nodes showed preserved fatty hilums.
How specific or sensitive is that? If it is there, can you rule out lymphoma?
So it was not ruled out, it was less likely.
We think less likely, but as per the experience we see, usually altered morphology is there in the lymph nodes. It's totally bizarre.
Now I would like to call Dr. Nipun Sharma to take the discussion further.
See, again, the point point which we were discussing earlier. Imaging can never give you the final diagnosis. Final diagnosis will always come from the pathology.
Mapping of the
To confirm our diagnosis, excisional biopsy from the right axillary node was performed by the Department of General Surgery under general anesthesia, and tissue sample was sent to the Department of Oncopathology for the histopathological examination.
general anesthesia.
Why axillary? Why not cervical? There are large nodes in the neck.
Sir,
Easily have been done under local anesthesia.
Sir, actually, previous FNACs was done from the cervical nodes, and they were.
I think FNAC is a good investigation, but until you have a very expert pathologist, pathologist doing it, it's a very difficult thing to judge upon it. And you miss out a lot many things. So what I think what Dr. Sir is saying is that you need to go in there, post minus 5 minutes job, 10 minutes job for doing the local anesthesia from the neck.
Is any consultant from Department of Surgery was done this? Any consultant or
Hello.
it's very unfortunate many relative faculty and patients are not attending.
Now, I would like to invite Dr. Neha from the Department of Oncopath to discuss the oncopathological findings.
Good morning, everyone. I'm Dr. Neha Jain, Senior Resident at the Department of Oncopathology. So basically, the specimen was received in the Department of Oncopathology. It was a wide local excision of the axillary lymph node, and the specimen size was 4.2 into 3 into 3 centimeter. It was a single grey yellow to grey brown fibrofatty piece of tissue with non-matted lymph nodes measuring 2.5 into 1.5 into 1 centimeter.
Wide local excision is your term or surgeon's term?
Surgeon's term.
Why?
So we do.
A node doesn't require wide local excision. Wide local excision is done for a test clump. Lymph node just requires the node. That's why I asked, is it your term or is it their term?
We also use this term. It's basically excised specimen of the lymph node.
There is a difference between excision and wide local excision. Wide local excision is with a peripheral circumferential rim of normal tissue.
Yeah, one second. So basically, microscopy was done for this case. It is a 100x H&E image, which shows a atretic or a regressed germinal center marked by the arrow yellow. And it is transversed by a prominent sclerotic vessel, which is marked by the arrow blue. So basically, this represents a lollipop, and it's known as the lollipop sign. In the background, we can see the mantle zone, which shows concentric arrangement of the lymphocytes. So because of the concentric arrangement of the lymphocytes in the mantle zone, this is also giving an onion skin appearance, which is characteristically seen in Castleman's disease. So based on these histomorphological findings, a final diagnosis of Castleman disease hyaline vascular variant was made. And immunohistochemistry was done to further support and confirm the diagnosis. So on immunohistochemistry, the first image basically represents a CD23 positivity in the follicular dendritic cells, which is present in the mantle zone. And the second image was done and basically represents the HHV8 was negative in our case. And in the third image, we can see that the mantle zone shows positivity for the reactive B cells by CD20 positivity is seen in the reactive B cells present in the mantle zone. In the fourth image, we can see that the mantle zone is positive for BCL2 while the germinal center is negative for BCL2. And in the last image, we can see that there is CD10 positivity in the germinal center while the mantle zone is characteristically negative for CD10. So basically, based on these findings, that is CD23 positivity in the follicular dendritic cells and BCL2 negativity in the germinal center, a final diagnosis of Castleman's disease, hyaline vascular type, was made. Now, I would like to call upon
This brings us back again to what VC sir was saying. This is a very rare disease. Now, this is what happens in the exam if you know the diagnosis. Now, in this case, if a student makes a clinical diagnosis of Castleman disease, at least I will fail him or her. It cannot be a clinical diagnosis. It is always a histological.
Thank you, everyone. I would like to call upon Dr. Nipun Sharma for further discussion.
That is why I always tell all students, don't try to find out the diagnosis. Once you know the diagnosis in the exam, your presentation becomes oriented towards justifying that diagnosis, and a good examiner will pick up that you know the diagnosis, and that is why you are presenting it like.
After histopathological examination, our final diagnosis was Castleman disease, hiding vascular type. We requested further investigations to see the etiological association of the disease, which were interleukin 6, which was elevated, hypergammaglobulinemia, and HHV8, which is frequently associated with the Castleman disease, was found negative. Now, to summarize our case, 70-year-old female with generalized lymphadenopathy, chronic low-grade fever and generalized weakness, erythematous papular rashes all over the body, hepatosplenomegaly, CCT showing multiple superficial and deep lymphadenopathy, PAT-CT finding was moderately aphasia with lymph nodes, which was likely a metabolically active disease. Histopathology revealed Castleman disease, high in vascular type, raised ESR and CRP, IL-6, and polyclonal hypergammaglobulinemia, and HHV8 and HIV was negative. So our final diagnosis is idiopathic multicentric Castleman disease, high in vascular disease. Now we'd like to invite Dr. Vijeta Niranjan from Department of Clinical Haematology to further discuss about the Castleman disease, its type and treatment.
Thank you, Dr. Nipun. Good morning to everyone. I'm Dr. Vijeta Niranjan, Senior Resident, Department of Clinical Haematology. So consultation from the Haematology Department was taken for the further management in a biopsy-proven case of multicentric Castleman disease of hyaline vascular type. Since this was the HHV negative, so final diagnosis of idiopathic multicentric Castleman disease was made. So what is Castleman disease? It is an uncommon heterogeneous group of lymphoproliferative disorder that shares a spectrum of characteristic histopathological features and have a variety of etiologies, presentations, treatments, and the outcomes. The histological hallmark in all the types are the angiofollicular lymph node hyperplasia, and it is important to distinguish the subtypes for a therapeutic perspective. The Castleman disease is further divided into two types, the unicentric, in which the one or more than one lymph nodes in a single region of body involved with no hypercytokine syndromes, and the next type is multicentric, in which the multiple regions of lymph node involved with the systemic inflammatory symptoms like lymphadenopathy, hepatosplenomegaly, cytopenias, and the multi-organ dysfunction. This multicentric further divided into two types, with the HHB association and without HHB association, that is the idiopathic multicentric Castleman disease. So our case was HHB negative idiopathic multicentric Castleman disease. To further elaborate, the unicentric Castleman disease, in which the one or more enlarged lymph nodes are present in a single region of body, and it is the most common subtype. Around 75% of the cases, it primarily affects the young females, and symptoms are typically milder as there are no usually no hyperkinetic syndrome, cytokine syndrome seen. Among the multicentric Castleman type, the first is idiopathic, in which the enlarged lymph nodes are present in multiple lymph node regions with no identifiable causes, and the symptoms are severe due to systemic cytokine inflammatory response. The next multicentric type is HHV associated. In this also, the enlarged lymph nodes are present in the multiple lymph node regions with the HHV8 infection. It is commonly seen in HIV positive patients, and presentation is similar to idiopathic multicentric Castleman disease. To diagnose the idiopathic multicentric Castleman disease, both of the major criteria and at least 2 out of 11 minor criteria should be there. And in our case, we got both the major criteria, that is the histopathological evidence of lymph node involvement and the enlarged lymph nodes in more than 2 regions, along with, and we got the 4 minor criteria, that is the elevated ESR and CRP, polyclonal hypergammaglobulinemia, the constitutional symptoms in form of fever and weight loss, and the hepatosplenomegaly. Now come to the management. The first line therapies of the unicentric Castleman disease, if the node is resectable, so surgery is the option.
Sorry, but rash is nowhere mentioned, and this patient had such extensive rash.
Sir, in this type, this eruptive cherry angiomata of the violaceous papule was mentioned in the minor criteria, but this patient does not have such kind of rashes.
Rash was not.
No, sir. Sir, but only 2, if more than 2 out of 11 criteria, it made the diagnosis.
Whether the skin lesions she had
fits into this definition or
No,
not?
sir. Sir, out of these, we got only these 4 minor criteria. The first line therapies in the unicentric Castleman disease, if the node is resectable, the surgery is the option. And if the node is surgically unresectable or if there is incomplete resection, the first is to observe the symptoms. And if there is symptoms in form of compression, then rituximab with or without prednisolone is the treatment. And if there is any primary inflammatory response, then anti-interleukin 6 antibodies like cetuximab and tocilizumab will be the treatment options. The first line therapies in the multicentric Castleman disease, in the HHB8 positive cases, the treatment options are the rituximab, along with the rituximab, the other combinations like anthracyclines, with or without prednisolones, and the use of antivirals and the other zidovudin will be the treatment options. And in the HHB8 negative cases, that is idiopathic multicentric disease, which was our case, the first line therapies include the anti-interleukin 6 antibodies like cetuximab and tocilizumab with CBP rituximab chemotherapy and the rituximab with or without prednisolone. So we have started the patient on RCVP chemotherapy every 3 weekly for total of 6 cycles that include the day 1 with the injection rituximab of 600 mg, cyclophosphamide 1200 mg, vincristine 2 mg, and the tablet prednisolone 100 mg per oral for 5 days. We saw the response to treatment in form of significant regression in lymph node enlargement, resolution of the rashes. This was the final response, and the improvement in the appetite and the low general condition, and the fever subsidence. Now I would like to invite Dr. Shalini Garg ma'am to conclude the case. Thank you.
So what is the duration of treatment and what should be the follow-up once you get a response?
Sir, usually the duration is, usually we give 3 weekly RCVP chemo protocol for 6 cycles. And after the completion...
And after that, after some time?
Sir, usually it does not recur, but we follow up the case, usually monthly follow-up was the... we keep the patient in the monthly follow-up to see any recurrence. Thank you.
So I would like to just tell the review of literature. Castleman disease itself is a very rare lymphoproliferative disorder with overall global prevalence of 3 to 5 per million person years. While unicentric is more common, that is 15 to 25 cases per million. Multicentric has 5 to 6 cases per million. However, in our case, we found multicentric disease. And also, this is in parallel to the reports in India. Among the diagnosed MCD cases reported in India, often they lack HHV8 association, which was similarly found in our case. However, in Western countries, the cases are more related to the HHV8. Castleman disease has a very rich presentation in Indian studies, being from pediatric till the elderly age group. And highly vascular variant is more commonly found in the unicentric one. However, in our case, we found a highly vascular variant in MCD1. Castleman disease is often misdiagnosed due to its rarity and the varied presentation with TB or lymphomas. And diagnosis is confirmed by lymph node biopsy and histopathology. So now I would like to thank MGUMST management, Emeritus Chairperson Sir, come Chancellor Sir, to our honorable dignitaries, CCR Core and Review Committee. Special thanks to Dr. Manoj Rakhotia Sir, HOD, Clinical Immunology and Haematology for guiding us. So he's what? Department of Oncopathology, Department of Clinical Haematology, Department of Radiology, Nuclear Medicine and General Surgery, and most importantly, nursing officers, staff, and most important, patient and their family. Thank you.